Yeah, Frankie, how do I know if they can hear my audio wise? You can? Okay. All right. Thank you. Hey, everyone out there. Sorry, my first time doing Facebook Live, so little technical glitches, but thanks for bearing with me for the last 3 minutes as I get on here. So, most of you may know me, but if those that don't, I'm Dr. Flannery, one of the orthopedic surgeons and physician owners at OSMS. And going through different times right now with this coronavirus pandemic, and thought this would be a good opportunity to reach out and try to get some of your questions answered in the safest way possible. Some of our first objectives is just to let you know what we're doing at OSMS to make it safe for people to come in. We really shut the doors immediately when understanding this problem better, and wanted to make sure we had all the protocols in place to really keep everyone safe out there. So anyone that has an appointment or that's looking to have surgery, we have a series of health-related questions to cover with them prior to the appointment to make sure that everyone that's coming into our clinic is safe. We're limiting the number of people in our clinics. We allow one patient visitor or caregiver, if we have a child in the clinic, to accompany them. And we're requiring all patients, guests, and everyone in the building to be wearing face masks. We have hand sanitizer stations throughout the building, and have put in social distancing procedures in place. All the staff are being monitored for any fevers or any signs of symptoms, and so far we've been very successful with getting back going and keeping everyone safe. So with that, kind of reviewing coronavirus, we'll try to jump into any questions that people may have related to that, related to surgeries or specific conditions. So starting to see some come through here. Um, One of the first questions is just asking about myself. So I'm a Wisconsin native. I'm from Antigo, Wisconsin originally. Grew up playing sports, football, basketball, and running track, and had some injuries along the way and got interested in orthopedics. And once I discovered medicine and learned more about orthopedics, it was just a great fit for me. I did my training down in Madison at University of Wisconsin for medical school and residency. And my wife and I now live in Green Bay, De Pere, with our two little girls, and we've been here for almost 3 years and have just loved it. It's been a great fit for us. So, moving on to other questions. One of the first questions is, what if I don't want to have surgery? Can I still come to see you? And the answer is, of course. You know, we're here to help every patient in any way that we can. And obviously, there's a natural fear of having surgery. That's a big deal, and we certainly don't take it lightly. Every patient that comes in the door, we're looking to help them in whatever way they feel is most beneficial. So there's a lot of different options. We talk a lot about low impact exercise, strengthening around the joint that may have arthritis or pain. The more the muscles do, the less the bones and cartilage have to work. There's formal physical therapy. There's a variety of bracing options, an array of injections that can be considered, and ultimately, even on the surgical side of things, there's a wide gamut of options, ranging from very minimally invasive with a scope up to joint replacement or even revision joint replacement. So those are some of the alternatives and things that we're looking at. It really comes down to how the problem is affecting your lifestyle, how limiting it is, how frustrating it is, what things you've tried thus far. Over-the-counter pain medication used correctly can really be helpful. The anti-inflammatory class, Tylenol, supplements including glucosamine, We have patients that have trialed CBD oil and found some benefit with some of these alternative treatments, acupuncture, massage therapy, chiropractic. All those things have a role and certainly can be considered. One question came up about different injection options. Pretty common to use injections in arthritis setting, particularly knee arthritis. Really three main injection options that we look at using, one being the classic corticosteroid. This is pretty reliable as an anti-inflammatory to settle down the knee joint, commonly can work for about 3 months. We worry about putting it in any joints that have healthy cartilage because there is a dose-dependent effect that it can hurt the cartilage over time. So we really limit this to no more frequent than every 3 months. And if we don't see success with that for at least 3 months' time, then we move on to an alternative option. Another option is called hyaluronate, rooster comb, Synvisc. These are some of the names for it. It's actually synthetic cartilage. So our knee or other joint normally makes its own cartilage lubricant. Often as we start to get arthritis or problems with the joint, it doesn't make as much of that lubricant. And so it can be synthetically made and replaced back into the joint. Works as a shock absorber and also just helps the knee move more smoothly. And that can be, beneficial both from a pain and a swelling standpoint, and will last in the knee for about 6 months. Commonly, it is covered by insurance for arthritis. Last type of injection that we use at OSMS is called PRP, or platelet-rich plasma. This is an interesting and different type of injection where it uses your own platelet cells. So we take a small sample of your own blood and spin it down and use the platelet cells as a healing mechanism with different growth factors and healing molecules that are held within inside platelets. So we can put that into the knee joint or other joint, and those platelet cells break open and release a lot of those healing molecules. And that can have beneficial effects up to a year. And really, that would be my go-to in a patient that's quite young. Maybe some wear and tear to the knee, but not truly getting into advanced arthritis yet. We're really trying to give something that's as safe as possible. So in this way, we're kind of giving your own body back to you, just in a concentrated form in the joint. So that can be a nice option. There was a question about stem cell therapy in joint. And so this is something that is absolutely being researched. A lot of our academic institutions are working on that as potential option. Unfortunately, there is not any current stem cell option available that is FDA approved that has been found to be beneficial. Unfortunately, there's a lot of people out there marketing stem cell injections as a very expensive option. And this typically involves either frozen tissue where the cells are no longer living, or a procedure where they take a sample of the patient's own bone marrow. But unfortunately, as we age, we have less stem cells in our bone marrow. So through that whole procedure, it's possible that you don't get a single stem cell. Whereas true stem cell therapy, we would look to take your own stem cells, grow it up in a lab, actually have hundreds of thousands of stem cells to be able to inject and then control how those stem cells function by trying to give them signals to make cartilage or meniscus to cause true healing. So unfortunately, that's not been found to be a viable option yet. So I would save your money on that one. Another question came in about hip replacement, specifically anterior hip replacement. This is a specialty of mine and a real passion and interest of mine. It's considered the newer kid on the block in terms of joint replacement, hip replacement, but really it's been in use for over a decade, and I think it has really become a nice option. The anterior just refers to the incision being in the front of the hip, but there's so much more that goes into it than that. It's really a minimally invasive option. where there's less tissue in the front of the hip. We're not having to go through the buttock muscles and some of the tendons that attach right on the back of the hip. We're working between the muscle groups and can allow those to lay back down at the end of the surgery. There's also a capsule layer that's right around the hip that is a nice thick layer that with anterior hip replacement we're able to preserve and tag the two sides of the capsule and at the end of the case actually tie those back together as if we weren't there. So that's really nice to not violate the structures in the back of the hip. This allows us to not have patients follow any hip precautions. So classically, restrictions include not bending the knee up past 90 or crossing the legs, kind of reaching down. Some fairly common positions with tying your shoes. Those are considered risks for dislocation with other approaches to the hip. But not with the anterior hip replacement. So really, in recovery, it's just letting pain and comfort be your guide with normal return to motion. And so that is a nice advantage to not have those precautions. And also research still shows that one of the common complications after hip replacement, which is dislocation or the ball of the hip replacement coming out of the socket, is much less likely. So 2% with some of the other approaches as compared to less than 0.5% with the anterior hip replacement. In my personal experience, that's the biggest advantage. I think that really helps me sleep at night. Other nice thing about that surgery is you get to lay flat on your back during the surgery. I use a specialized table for that. This allows us to bring in an x-ray machine during the surgery so that we can take pictures throughout as needed to make sure that the hip replacement that we're putting in is the correct size, that it's in the right position, that leg lengths are equal, and that we've kind of met all the important criteria before leaving the operating room, as opposed to getting an x-ray in the recovery room where it's a little late to be making changes. With the specialized table, incision is typically just over 4 inches, so really minimally invasive incision over the front of the hip, and we've had that heal up well. That allows you to typically get going a little bit sooner with less pain medication. Studies show on average about 2 weeks sooner getting rid of the walker and the cane and getting back to the things that you'd like to do. So that definitely has been a nice surgery for us. Question about do you need a referral to see us at OSMS? And the answer is generally no. We have a walk-in injury clinic and are happy to see any patient that comes through our door. It is a good idea to check with your insurance to see on coverage. Sometimes it's recommended to have a referral sent from your primary care physician from an insurance standpoint. Question about telemedicine. So we have really started utilizing telemedicine. It's been a nice option that I think we will continue to utilize going forward. We have patients that come down to see us from Upper Michigan and from several hours away in different directions. And certain situations, the main purpose of the visit is to talk and just see how the patient is doing. With the telemedicine, we can still visibly see each other, take a look at the incision. You can demonstrate range of motion so we make sure that you're making appropriate progress. But it can save a trip to the office. It can save the concern with the current pandemic of exposure to coronavirus. So we do look to make that option available to everybody. So moving on, other questions. See some questions about knee replacement. So knee replacement, I think it's important to know different options about knee replacement and what to expect. So when the knee is worn out, it can be replaced. The incision is over the front of the knee. And sometimes I have patients ask about restrictions after that surgery, whether you can kneel on it, what other activities that you can do with a knee replacement. And we found that with following a protocol for a return to kneeling, over 90% of people can comfortably kneel on a knee replacement. So there's a variety of things that can help with that. Massage over the incision, starting with kneeling early on, and progressively going to firmer and firmer surfaces over the course of 4 to 6 weeks. And then patients are typically very successful with that. Knee replacements, there's really two main types of total knee replacement. That's where we're replacing all the surfaces of the bone because the knee is generally worn out. Those two types, one is called a cruciate retaining. It means that you keep one of the ligaments in the center of the knee. There's the ACL and the PCL in the center of the knee. These ligaments help with stability. So with a CR knee, we do keep the PCL. Some advantages with that, I think, include a little bit of more feedback from the knee, a little bit more natural feel. The alternative option is called a PS knee. This is where the plastic insert of the knee replacement has a post on it. And so that post is used to stabilize the knee, and you can remove both the ACL and PCL. This is a really nice option as well. Half of the knees in the country use each of those two options, so it's really pretty split. PCL release and using a post, I think, results in pretty reliable flexion or bending of the knee after surgery. There's also options at times to replace a partial aspect of the knee. So there's three main compartments to the knee, and it makes sense to only replace the portion that is worn out if possible. So when criteria are met for that, sometimes you can just replace one of the three compartments of the knee. And this certainly allows for generally easier recovery, better early range of motion, less need for pain medication, more likelihood of going home the same day or the following morning. Patients that are into racket sports and really high demand with the knee, if they are looking to keep that highest level function, a partial knee replacement can be a nice option. People ask, with a total knee replacement, what can I do? Well, commonly people get back to golfing and have no trouble with that. Typically, they're able to play doubles tennis or competitive tennis, but in a little bit lighter fashion. Downhill skiing, I've had patients get back to. Generally, you want to avoid mogul sections and anything too aggressive, but certainly we have people downhill ski, water ski, and get back to some of those activities. So there's certainly options on that replacement front that we look at. With a partial knee replacement, we've found that patients over 75 are just as likely to have that the remainder of their life as compared to a total knee replacement, and obviously with less recovery, an overall easier process than with a total knee replacement. So that has been successful as well. You also have patients that can be very young for knee replacement, and they say, "Well, I'm too young for a total knee replacement. Doc told me I had to be 60." I think generally we're finding that our materials are better. Each and every day, the plastic inserts that are being used for the knee replacement are ran through the lab with millions of cycles, and they're holding up better with less particle kind of wear or the risk of it wearing out. So commonly we feel confident over age 55 that patients that aren't going out running marathons have a good chance of it lasting their lifetime. Patients that are younger that may have had a traumatic injury to the knee, or for whatever reason their knee is wearing out sooner, if it is a single compartment, uh, partial knee replacement I think could be considered a little bit sooner than total knee replacement. If you do undergo a partial knee replacement uh, at age 45 or 50, unfortunately, you're expecting to have another surgery throughout your lifetime, but converting a partial knee replacement to a total knee replacement can be a little bit more predictable surgery with less bone loss than trying to convert a total knee replacement to a new total knee replacement. So just looking for other questions here. One question that came through was talking about specifically do the surgeons at OSMS specialize in certain areas? And we absolutely do. We certainly try to be kept abreast with our skills so that anyone that walks in with an injury, whether that's a child or an adult that has a fracture, that we're all comfortable in managing that either with a cast or a procedure to help get them going. But naturally, we've all found areas of interest in our practice. We all know each other's practice well and know who would best serve each individual patient. So commonly, when you come through the door, any of the initial management can be taken care of. Decision on whether an MRI or X-ray is warranted right away, or if we start with some therapy or consideration of a brace or injection. And then when it goes to that next step, and really find a specific pathology, whether it's a tendon tear to the hand or arthritis at the ankle. We do have people that really specialize in hand surgery, foot and ankle surgery. Others that specialize in sports medicine, including ACLs and rotator cuff repairs. And then also the joint replacement category, hip and knee, shoulder replacements, ankle replacements, also seeing some wrist and elbow. So really, it's kind of the full breadth that we look to cover. Some of those specialists in hand, we have Dr. Zellner and Dr. Knox, who will be starting with us shortly down in the Appleton area. And we also have in foot and ankle Dr. Henriksen and Dr. Kerwin. And then at the joint replacement realm, we have a variety of surgeons that are absolutely amazing. Some names that are familiar: Dr. Grace, Dr. Tressler, Dr. Sullivan, Dr. Enright, Dr. Klein, could continue on, Dr. McCormick. Dr. Miller is one of our partners that really specializes in complex revision joint replacement, and so he has been invaluable with some of the toughest cases, including replacing part of the entire femur and coming up with a hinge knee joint, or really trying to get something to supplement bone in people that have had problems after prior surgeries. And so we often do those complex cases together with at least two surgeons to really make sure that we're limiting the time in the operating room and not fatiguing, and really getting our patients the best outcome possible. So quite a bit of a rundown there. I hope everyone had found something interesting that they could take, and hopefully this is an event that we can continue to do in the future, and answer questions just off the cuff with a natural flow, allowing people to get as much information as possible in a safe, comfortable environment. and hopefully we'll turn the corner with this coronavirus pandemic. We certainly have seen numbers declining and our safety improving, and look forward to seeing you all in person and really getting to interact that way as well. So with that, I hope everyone has a great evening, and we'll see you next time.